Assalamualaikum everyone. The event will start in another 5 minutes.
Okay.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. And a very good morning I bid to our speaker and to all participants. On the behalf of the organizing committee, we would like to welcome all of you to Weekend Booster, a program organized by the Academic Bureau of IUM Medical Society, MED. Before we begin the session today, let us start with the recitation of Ummul Kitab Al-Fatiha. Dear all participants, please fill in the Google form via link provided for your starpoint. Today, we are going to have our speaker, Dr. Aqlan, to speak on heart failure. Without further ado, I would like to invite Dr. Aqlan to start his session.
Can you hear me? Tes tes dengar tu. Tes 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 dengar tu. Hello. Tes 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 dengar ke?
Dengar, Doktor.
Ya, sorry, masalah dengan mic tadi. So, Assalamualaikum warahmatullahi wabarakatuh and a very good morning I bid to all. So, thank you, Max, for this. I think it's a good effort. It's a new program, I think, previously not done before. So, I would like to take this opportunity to congratulate Max on organizing such a program. And good morning also to all of my beloved friends. So inshallah today without further ado, let us start this presentations today. I'll present to you the screen. Just a second. Okay, Assalamualaikum warahmatullahi wabarakatuh. So I hope all of you can see my slide. If there is anything that is not clear or you want to ask for any questions or clarification, you can just stop me anytime. So all of you can see the slide, right? Okay. So, inshallah today I will be giving a topic on heart failure. So, this is actually just a sharing session, not really a teaching session. And most of my points gathered today and my presentations are gathered from textbook, Kuma and Clark, Harrison, our current CPG, the fourth editions of heart failures, as well as some of the sharing points from Dr. Farhana, as well as Dr. Umu Afira back then. So these are my compiled notes for my back then when I was in final year. So, inshallah, first we need to go into the definitions of heart failure. So, as we all know that the different textbook, different books, reference book have different definitions of heart failures. So, heart failures in general is a clinical syndromes that is defined. It has occurs due to a structural or a functional abnormality that results in the inability of the hearts to meet the metabolic demands of the body, or it can do so, but it must have a higher normal feeling pressure. So different textbook have different classification or different definitions for heart failures, but in general the essence of it is the same. The heart is failing and is unable to meet the metabolic demands of the body. So having said so, heart failures is a clinical diagnosis where the diagnosis is made based on clinical signs as well as clinical symptoms and supported with investigations such as radiographic finding, ECG, as well as the echocardiogram. Okay. Moving on, so we have a few methods of classifications of heart failures. So first, we have the clinical classifications where we can classify into acute versus chronic heart failure. So we have a chronic and stable heart failures, and interspace in between the stable periods will be episodes of decompensation. So it is of similar with asthma, for example. So we have the bronchial asthma, and we have episodes of acute exacerbations. Same goes with heart failure. Same goes with COPD. So these are chronic and relatively stable conditions, but interspersed with episodes of decompensation. So second classification is we do so based on the echocardiograms where we will calculate the ejection fractions. And with that, we can stratify heart failures in three categories with reduced ejection fractions, uh, mid-range ejection fraction, as well as the preserved ejection fraction. So we'll talk about the ejection fraction later on. So basically, based on these calculations, we can stratify into three categories. 40% or less will be those with reduced, 50% or more will be those with preserve, and in between 41 to 49 will be those with mid-range. So having said that, um, the mid-range as well as the preserve as well as the reduced ejection fraction, all of these have different pathogenesis and pathophysiology. So we will look into that later on. So those with reduced ejection fractions is basically the heart have dysfunction in terms of its systolic function. So the abilities of the heart to contract in order to expel the blood into the peripheral circulation, that is what we call it, the systolic function of the heart is undergoing dysfunction. And for the mid-range as well as for the preserved ejection fraction, the the systolic function is intact, but rather the diastolic function of the heart is impaired. So diastolic function of the heart refers to abilities of the heart to relax and dilate its chambers in order to allow the blood to flow into its atrium as well as into the ventricles later on. Um, so this will be problematic in cases where the ventricles, the chambers in itself undergoes hypertrophy or it's stiff. So it cannot relax as a normal heart can do so. So the diastolic function will be impaired. So there will be less blood to fill in the beginning of at the end of the diastolic functions. Hence, less blood will be ejected during the systolic, despite a good systolic function. So diastolic functions diastolic dysfunctions occurs at mid-range as well as the preserved ejection fraction, whereas for those with reduced ejection fraction, they will have the systolic dysfunction. Now, I talk about ejection fraction, so let us talk a bit about what constitutes an ejection fraction. So ejection fraction is the fractions of blood that is ejected from the heart during systole into the systemic circulation. So we need to understand few terminologies. So first we have the stroke volume. So stroke volume refers the volume of the blood at the end of the diastolic minus the end of the systolic volume. So we know that diastolic is the relaxation function of the heart. At the end of the diastolic, there will be some amount of blood within the chambers, within the ventricles of the heart. Then we will have the systole of the heart. At the end of the systole, there will be some blood left after the heart has contracted. So the end of diastolic volumes minus the end of the systolic volumes within the chambers constitutes the stroke volume, which is the amount of blood that is ejected into the systemic circulation. So actually refers to this particular formula, stroke volume over end diastolic volumes times 100. So why we need to know this? Because I would like to give a few analogy examples in order for us to better understand what is meant by reduced ejection fraction, what is meant by mid-range, and what is meant by preserved ejection fraction. So let's take a look on some of the example. So this example I quoted from Dr. Farhana in order for us to better illustrate this concept. So let's say we have a normal heart. So at the end of the diastolic of this normal heart, there will be 100 milliliters of blood within the chambers. Then systole will ensue, the hearts will contract. At the end of the systole, there will be 40 milliliters of blood left in the chambers after the heart has contracted. So how many blood has been ejected into the systemic circulation? So we just minus end diastolic volume minus end systolic volume, so we get the stroke volume. So 60 milliliters of of blood has been pumped out from the heart into the systemic circulation. So when we calculate the ejection fractions of this particular example, so we just take stroke volume over end-diastolic volumes times 100%. So let's say for this particular examples, we're gonna take just a second. Okay, so 60 over 100 then times 100%. So it will have a 60% ejection fraction. So this is a normal heart. So let's say we have those with reduced ejection fraction, or where the definitions refers to 40% or less. So this refers to those particular heart failure patients that have a systolic dysfunction. So let's say we have at the end of the diastolic filling, we have 100 cc as per the first example. Then because of the contractility of the heart is impaired, the heart is to eject of blood. So at the end of the systolic, there will be a high amount of end systolic volume. Let's say, for example, we take 70 cc, 70 milliliters of blood that is remaining within the chambers at the end of the systolic. So the stroke volume, or the amount of blood that is injected into the systemic circulation, will be only 30 cc, where we 100 cc minus 70 cc, we only have 30 milliliters. So the ejection fractions of this particular heart, because of the systolic dysfunctions, will only be about 30%. Now, let's take a look at another example where we say that those with mid-range and those with preserved ejection fraction, the heart failure is actually having a diastolic dysfunction instead of a systolic dysfunction, where the heart is unable to relax, so less blood will enter, less blood will be retained within the chambers before the heart is contracting. Hence, less blood will be ejected out. But because we are talking about ejection fraction as a percentage, hence we will have the preserved ejection fraction. So let's take a look at this particular example. Just a second, I will.
Doctor, excuse me. Sorry to
Yeah.
interrupt. There's macam disturbance sikit dekat microphone. Macam bunyi bising sikit. Uh.
Oh, sorry.
Ah,
Previously clear ke semua yang lain? Points.
dia macam bunyi ni sikit. Ada disturb.
Sekejap. Sekarang ada lagi ke bunyi tu?
Cuba rapatkan dekat mikrofon sikit.
Hello?
Ah,
Ada lagi ke bunyi tu?
dah tak ada dah. Clear
Okay.
sikit.
Alright. So anything just before this point semua clear dia kan? Okay. I would like to continue. So I just stop it because my microphone I have some problem tiba-tiba dia begini. Okay. Anything nak clear just voice out because we don't have okay. So moving on back to the points before that we have the those with ada lagi ya. Just a second. Ada lagi ke bunyi tu? Hello, test. Ada lagi ke bunyi tu?
This time better, Doctor.
Okay. Macam mana ya? Kita apalah, just continue. Okay. Those with so so we going back to the point. Or more of the ejection fraction calculation. This particular heart failing, so it is not failing in position. So imagine a heart where it cannot relax as a normal heart can do so. So because of the inability of the heart to dilate its chambers during diastole, hence less blood will be filled into the blood. So into the heart. So at the end of the diastole, so we only have the end diastolic volume for only 60 milliliters as compared to the normal heart, 100%, 100, 600 milliliters. And then after that, at the end of the systole, let's say a total amount of 30 milliliters of blood will remains in the chambers after systole. So if we minus the stroke, calculate the stroke volume, so the end of diastolic volume minus the end of systolic volume, so we will only have the 30 milliliters. Just a second. Korang nampak slide lagi ke?
Sorry, Doctor, we can't hear you.
Can you guys still see the slide?
Yes, but we can't hear your voice clearly. Kalau Doktor tak guna earphone boleh ke?
Okay, try.
Okay, thank you.
Clear ke sekarang?
Yes, much clearer.
Okay, sorry. Alright.
Alright.
So again, and calculate the stroke volume. So 60 minus 30. So we only have a stroke volume of 30 milliliters. So these are 30 milliliters are the amount of blood that is ejected into the systemic circulation. So we calculate the ejection fractions, 30 divide by 60 times 100%, then we will get 50% or those. So it is within the range of a preserved ejection fraction. So I think this concept is important because it will tell us why do we differentiate between reduced, mid-range, as well as those with preserved ejection fraction. So this is an analogy or a parable that we can use. So imagine a normal heart as a balloon. Once we fill in the balloon with water, then it can expand. So that reflects a good diastolic function of the balloon. So the balloon can expand, hence more blood or more fluid can be entered, it can be filled within the chambers. So imagine if we are to do the same thing with a ball, where the ball will be expanded to only a certain amount of volume, Hence, after that, we cannot fill in more fluid or more blood into the particular blood ball. So this ball reflects an analogy for those with having a stiff ventricles or hypertrophic ventricles, which reflects diastolic dysfunctions. Now, these are some of the causes of diastolic dysfunction. So you can take a look at CPG. It listed a good amount of them. So this, in essence, those with diastolic dysfunctions, the heart is unable to relax. Hence, less blood will be entered into the chamber. Hence, the end diastolic volumes, the volume of blood at the end of diastole will be less, leading to also a heart failure despite the good ejection fractions. Okay, now we're gonna take a look at causes of heart failure. So we need to differentiate between the causes of heart failure per se, as well as the causes So these are the list of causes of heart failures. In other words, these the commonest causes includes coronary artery disease, hypertension, dilated cardiomyopathy, valvular heart disease, and so on. So there are some less common causes of heart failures. For example, we talk about endocrine causes such as thyroid disease and also connective tissue disease, but such causes are rare, and we don't routinely screen for them unless there is a diagnostic uncertainty where we already screen the commonest causes, but there is none, but the heart seems to be in failure state. So back then, we have a patient in Susmac. The patient was a Malay female, about 30-something age, young. There is no comorbid in such patients, but the heart is in a failure state. The patient presented with symptoms of heart failures. There were signs of heart failures, and apparently the ejection fractions was reduced on echo, and chest radiographic is also suggestive of heart failure. So, but because of there is no causative factors identified, so back then, Dr. Umu ordered thyroid function test as well as the connective tissue workup is as part of the screening for all other causes of heart failure. So in other words, we don't regularly or routinely screen for these various causes until we already excluded the commoner ones. Okay. Now we take a look at causes of acute decomposition. This is also taken from CPG, fourth edition. So you can have a look. We can differentiate between patient factors, cardiac causes, systemic condition, as well as others. So if we go to the ward, one of the commonest causes will be non-compliance towards restriction of fluid, non-compliance towards medications. So these are like I would say constitute the majority of the patient presented with acute decompensated heart failure. However, before we want to say these particular patients having the acute decompensation because of non-restriction to fluid or non-restriction to medications, we also need to ask for all other causes, because all of these are important, and Dr. Umu specifically mentioned that we don't want to hear restriction of fluid straight away, but we need to mention that we need to show to the examiner or to the attending doctors during round that we already ruled out all the other causes of acute decomposition. So just mentioned, a patient have no symptoms of acute coronary syndrome such as nini, and so on. So this must be taken during interview and also must be presented during our clinical presentations. Okay. Now, these are some of the clinical features of heart failure. I'm sure most of you already familiar with these particular symptoms and signs. So patients typically presented with bilateral leg swelling. The patients will have paroxysmal nocturnal dyspnea, where the patients have sudden episodes of awakening at night because of the shortness of breath. Patients having orthopnea. So orthopnea, we must quantify how many pillows the patients must must sit on during when the patient is sleeping, in order for us to quantify the severity part of it. It must be presented during our presentation. Patient will also have fatigue, and also there are some signs that is classical of heart failures. Patients will have tachycardic, the jugular venous pressure will be elevated. Patients might have a cardiomegaly, and on auscultations, we might or might not detect a third or fourth heart sound. And of course, the bibasal fine crepitations will be present in the lungs for those with acute decompensated heart failures, complicated with acute pulmonary edema, and of course peripheral ankle edema, ascites, and also hepatomegaly. And a common questions would be the term cardiac asthma. So the cardiac asthma is actually not asthma per se, but it's actually a bronchial response in response towards the acute pulmonary edema. So because of the edema, it will stimulate the bronchospasm of the bronchial tree, hence causing the presentations of wheezing, what we call as the cardiac asthma. So it's not a true asthma per bronchial asthma per se, but it is because of the hypersensitivity of the bronchial tree leading to bronchospasms in response towards the pulmonary edema. And another term that is commonly asked would be the cardiac cachexia. So cardiac cachexia, those with long-standing heart failures will have a cachexic body. So this is in because of the catabolic state of heart failure. So heart failures will have a reductions of the systemic perfusions, hence there will be release of stress hormone. For example, catecholamine. These are catabolic hormone that will lead to the breakdown of the body in whole. So this will lead to a cachexic state for those with long-standing heart failures. Another point, this is actually take this point from Dr. Nick Nguyen. So we have right-sided heart failures and we have the left-sided heart failures. So congestive cardiac failure or CCF refers to a biventricular heart failures where both left and right-sided chambers of the heart are failing. So that's what we call as CCF. This is I would say I don't find it in textbook, but this is the verbatim from Dr. Nick Nguyen. So these are the NYHA classification. In order for us to stratify the severity of those having heart failures, also must be presented during our clinical presentations. So class 1, class 2, class 3, and class 4. So you can read these particular details. Also, it is used for prognostication. So we can calculate or estimate 1-year mortality of those patients having heart failures based on the NYHA classification. The complications of heart failures, we must also take note during our clinical interview and must be presented during our clinical presentation as part of the HOPI. So we have the cardiogenic shock. Symptoms includes dizziness, confusion, and then we have the signs of cold periphery, capillary fill time that is increased, and also and also pulmonary, and then we can have arrhythmia and also cardiorenal syndrome. So arrhythmia, because those with heart failures, it is predisposed to type 3 and type 4 would be a renal pathology leading to the cardiac pathology. And also type 5 will be a systemic condition affecting both kidney and also affecting the heart, cardiorenal syndrome. So the details of cardiorenal syndrome you can actually read in the CBG also included. Of course, moving on, after we completed our clinical history and clinical examinations, we will proceed with the investigation. So this will be part of the management. So first, we would like to do the classical bedside, blood, and also the imaging classification of investigation. So as for the bedsides, we can do ECG, and also ECG is used for us to detect the presence of a previous infarct in the form of a pathological Q wave, or we can also use the ECG to detect the precipitant of the acute decomposition of the particular heart failure. For example, we can see the signs of acute coronary syndrome in the form of the ST changes. So this can give us a clue of what might be the precipitant of the acute decompositions of the heart failure. And also the extrinsic for, of course, part of the risk factor screening, because the coronary artery syndromes, actually the coronary artery disease, the risk factors includes diabetes mellitus. Blood investigations, ABG, arterial blood gases, to determine if the patient is in respiratory failures or not because of the acute pulmonary edema, and full blood counts, because we want to detect the causes of acute decomposition heart failures, because one of the causes will be infection. So we can see the lymphocyte count, we can see the neutrophil count per se, and also anemia is one of the causes of acute decompositions of heart failure. And then we have the fasting glucose, part of the cardiovascular disease risk factor, lipid profiles, renal profiles, because of the cardiorenal syndrome as part of the complication. As for the other more, I would say more special tests that is being done, for example, the BNP or the thyroid function test or CDD screening, these are not routinely done, but only done in the cases of diagnostic uncertainty. So for your information, SASMEC do send BNP and the NT-proBNP to outside lab in the cases of diagnostic dilemma. Otherwise, as I mentioned before, that heart failure is a clinical diagnosis, can be diagnosed from the clinical symptoms and signs and supported by the radiographic finding as well as the echocardiogram. Imaging would be the chest radiograph. So a mnemonic Dr. Farhana shared with us back then was ABCDE, would be to describe the findings that we can see on those having the acute pulmonary edema for those with heart failure. So A refers to alveolar edema, B, curly B line, C, cardiomegaly, D, dilated upper lobe vessels, and E would be efficient. And then we have the echocardiograms. Of course, as I mentioned before, once we know the patient is in a heart failure, so we can stratify them based on their ejection fractions. Either it is reduced, mid-range, or preserved. We can also take a look at the cardiac dimensions, at the in particular the chambers of the heart, the atrium as well as the ventricles, in terms of the wall thickness and so on. And also we can check for the valvular function, because one of the causes of heart failures is valvular heart disease. So we need to have a look at that particular valve. Of course, this is basically just some of the signs that we can see on radiograph, reflecting those with having heart failures. So I've shared this before in the previous sharing, that we have two patterns of edema, either interstitial edemas or alveolar edema. Interstitial edema is when the congestions of the pulmonary circulation, the venous pressure is less than 30 millimeters mercury. So the fluid is restricted within the interstitiums of the heart. So once we have more congestion, so the venous pressure will be elevated more than 30 millimeters mercury, hence the fluid within the interstitiums will start to enter into the alveoli. So this is what we call as the alveolar edema. So the demarcations of 30 millimeters mercury actually taken from Radiopedia. It's not clinically used to, but it is good to know. It is a theoretical aspect. From interstitial edema, it will progress to become alveolar edema, giving rise to the classical bat-wing appearances. Now we've moved on. We covered about the clinical signs and symptoms. We covered about the causes of heart failures, causes of acute decompositions. We covered about the investigations. Now when we move on to the management of acute heart failure, after this we will have a look at the management of the chronic heart failure. So first and foremost, we need to determine the setting of the patient's care. So I would like to just share a bit. So when we want to answer the examiner, so we don't just rapidly shoot into, for example, what is the management of heart failure? We straight away go to, for example, beta blocker. So no, so we need to have a structure of answering the questions, so that we will look more structured. And the second thing is that we can have more time to actually plan within our head. So first, of course, we need to plan the setting of care. So we must admit the patient as an inpatient, and then we must resuscitate the patient, establishing the ABCDE. At the same time, we must take the necessary investigation. So if the examiner asks us, how do you manage the patient? So don't forget to include investigation as well as the management. So this part these two components part falls under the how do you manage the patient under the patient's management per se. So these are some of the criteria for us to admit the patients either in ICU, CCU, or in just a normal ward lah. So these particular conditions we can put in the ICU or the CCU. Okay, so after we already resuscitate the patients, take the necessary investigation, so we must institute the definitive care of the patient. So first must be supportive care of oxygen therapy, indicated if the SpO2 is less than 95%. The aim, of course, to maintain it above 95%. So there is a statement in CBG mentioned that a routine uh, administration of oxygen therapy in cases of non-hypoxic patients, those who having a SpO2 of more than 95%, it is not recommended because there's a risk for vasoconstriction in such patient. Of course, the modalities we can give using the high flow nasal cannula, and also we can give the non-invasive ventilations, the BiPAP or also the CPAP. So the CBG mentioned that both CPAP as well as the BiPAP are of similar efficacy. It is only the matter of which one is available at a particular setting. So these non-invasive ventilations are indicated if we already put the patients on the high flow nasal cannula, but the SpO2 is less than 90% despite the high flow oxygen. So we need to put the patients on the NIV, non-invasive ventilation. If still the patient is deteriorating, then IV intubation. So these are the criteria for us to when we want to do the intubation for cases of heart failure. Of course, second point of management will be the administration of diuretics to promote diuresis in order to alleviate the congestions of the heart. So the aim of diuretics is actually to reduce the body weight by amount of 0.5 to 1 kg per day. So this is the aim of reductions by use of diuretics of the body weight. So when we have this value 0.5 to 1 kg, if it is less than that, it means that the dosage of the diuretics is not adequate, or the disease in itself have a resistance to diuretics. So the modalities that we commonly use in ward will be IV furosemide. So we can give 40 until 100 mg in terms of the dosage. So these are the initial dose that is recommended, that is being used for those with naive. In other words, those who have never been on furosemide. We give IV 20 to 40 mg. For those we already previously on furosemides oral, we give 40 to 80 mg diuretics. So the aim is 0.5 to 1 kg of body weight reductions per day. The third point will be vasodilators. The aim would be to dilate the vessels in order to reduce the afterload as well as the preload, hence provisions of the symptomatic relief. But it is not to be used if the initial systolic blood pressure is less than 100 millimeters mercury, as it have a risk of hypotension. So choices of drugs include nitrates and nitroprusside. So if the SBP is less than that, we don't use it. If it is more than that, we can consider to use it. Then the fourth would be the inotropes. So inotropes will be used in those with having cardiogenic shock. So not all heart failures will have cardiogenic shock, and hence not all heart failure patients require inotrope support. If the patients have symptoms of low cardiac output, then then we need to institute the patients on the inotropic support. Morphine. So morphine actually I've never seen it used in ward, but CBG stated that the use of morphine it may reduce anxiety and dyspnea. However, such use of the medications is not recommended because of the insufficient evidence, and in our clinical practice, we don't see morphine being administered to those having heart failure. These are the flow chart of management, if we would say. We can see this in CPG of heart failure. This is for the acute heart failure. So, of course, mentioned before, oxygen therapy, diuretics, vasodilators if required, and also inotrope support if required. These are the dosage that we can refer as part of the management plan. Okay, of course, after that, we need to monitor the patient's clinical condition. The patients, after having such therapy, we need to monitor their response towards the therapy that we institute upon them. So we can determine the response based on the signs and symptoms, of course. We always ask for the signs and symptoms, check for the signs, ask for the symptoms during our rounds, and checking especially for the vital signs, especially the SpO2, the heart rate, the pulse rate, the respiratory rates, the blood pressures, the urine output, and also, as mentioned before, body weight, because we need to calculate do we achieve the aim for body weight reduction or not after the administration of diuretics. Of course, investigations would be pivotal as part of the clinical monitoring. And the last point will be the response will be is deemed to be adequate if the patient shows the following improvement. So improvement in terms of the clinical signs and symptoms, the periphery becomes warm, indicating that the patient is not in shock, the heart rate is reduced, SpO2 increase, and of course improvements of the urine output, essentially indicating that the patient is not in shock. Of course, after we institute the initial care, as I mentioned before, we need to consider when we want to add on other pharmacological management. So for the diuretics, previously we give IV in the point of acute setting, but we need to consider to change to oral after the patient have showing the resolution of the sign and symptoms or the sign of congestions, and the patient is already achieving his dry weight before his patient is presented with shortness of breath. Before that, before patient having congestion, the patient will be having a dry weight. That when the patient is not congested. So when the patient achieves this, we can change to oral medication. How do we know the dry weight? We can ask from the history if the patient know. And then second, ACE inhibitors or ARB. So we give ACE inhibitor after the BP has been stable for at least 24 hours. So we must also ensure that the systolic blood pressure is more than 120 millimeters mercury before we want to institute the ACE inhibitor during the acute setting. After, we must ensure that the BP is stable first. If the patients cannot tolerate ACE inhibitor, as presented with a dry cough or presented with angioedema, then we can opt for ARB, angiotensin 2 receptor antagonist. And then the third point will be beta blocker. So beta blocker is we don't give it during the congestive period. So we need to ensure that the patient is no longer congested and the BP is stable. Only then we can commence the patients on beta blocker. So beta blocker, in other words, will be used later on, in not during the congestive acute period per se. And then the fourth one will be the mineralocorticoid receptor antagonist or the spironolactone. So this can be commenced at the initial care. For the fifth drugs will be the ARNI, angiotensin receptor neprilysin inhibitor. But currently, as of current, there is no evidence for us to suggest the institutions of the ARNI medication during our acute episode. So in other words, we change IV diuretics to becomes oral. After patient is stable, we can start the patients with ACE inhibitor. After patient is stable, BP is stable for at least 24 hours. We can start beta blockers after the patient's BP is stable and patient is no longer in congestions. And also MRA can be instituted after the patient is stable also. Then after that, after we monitor the patient is stable for at least 24 hours, then we can consider discharge of the patient. So that is actually in summary of what we do for patients with acute decompensated heart failure, those presented with acute decompensation. These are the points that is being used for us to give the care to the patient. Now we move on to the next part, which is the management of chronic heart failures. So as I mentioned before, after the patient is stable, then the patient will be discharged. So these will be the points on for us to manage chronic heart failure. So we have the non-pharmacological as well as the pharmacological management. So non-pharmacological management, of course, educations, we must, very important, but often missed, is actually we need to educate the patients on the disease per se. We need to educate on the signs and symptoms. We need to educate on the dry weight of the patients. And we need to educate the patients on how to monitor the dry weight. I will touch on this later on. Of course, exercise training, and those with NYHA 1 to 3, it is encouraged to do aerobic exercise 5 times per week, each session about 30 minutes. And then diet and nutrition, of course, because as I mentioned before, that we must avoid additional salt that is being added to our diet. And also we need to give a good balanced diet for the role of energy provision, because as I mentioned before, that those with chronic heart failures will be in a state of cachexia. And of course, fluid restriction. So how much we should put the patient on restriction of fluid. So general recommendations will be 1 to 1.5 liter per day. But CPG mentioned that it must be individualized according to the patients. So 1 to 1.5 liters per day for those having normal renal function. Otherwise, those with impaired renal functions, we must put it on a lower fluid restriction. Lifestyle modifications, sexual activity and psychosocial support. So sexual activity, those using the vasodilators, we must not give the patients on sildenafil, the Viagra, because it can lead to profound hypotension. Of course, psychosocial support will be also important. Okay, all right. Now, pharmacological management. So, of course, part of the MCQ questions that is commonly asked would be which drugs can improve the survival of patients for those having heart failures with reduced ejection fraction. So, these are the list of drugs that has such benefit: ACE, ARP, ARNI, beta blockers, as well as the mineralocorticoid receptor antagonists or the spironolactone. So, diuretics have no is not proven to improve the survival of the patients in those heart failures, but it is pivotal during the acute care to alleviate the congestions. Okay. So we have diuretics. So as I mentioned before, after we convert the patients from IV diuretics to becomes oral diuretics, so we must educate the patients on dry weight management. So if the patients within a span of 3 days have an increment of more than 2 kilograms as compared to their dry weight, so they need to increase their dose of their oral medication. If there is no response, or if there is accompanied with worsening of the signs and symptoms of heart failure, then the patients must seek immediate medical attention. This is why we need to educate the patients as part of the patient education is on the dry weight management monitoring, as well as when to see medical attention. And then the diuretics of choice would be furosemide, the type of loop diuretics. Another choice would be a thiazide diuretics. And CPG mentioned that we can combine between a thiazide as well as a loop diuretics. However, such combinations are more prone towards more side effect, for example, hypertension, because we have two diuretics acting together. But it is mentioned in CPG, but usually we give only one of the two. So we have these are the type of the diuretics that we can use, and also its dosage that is being listed in the CPG. Second drug that we need to give in patients with heart failures, chronic, stable, is ACE inhibitors, or we can also give the angiotensin II receptor antagonists. So those with ACE intolerance presented with angioedema, or those having a dry cough, then we need to change to ARB. So, but both of these drugs are not to be combined together because it has more adverse effect. Because both acting on the same system, RAS system. So these are the drugs, the drugs, and also the dose that we can use as being listed in the CPG. You can read later on. So as I mentioned before, that ACE and ARB are instituted once the patients have a stable BP for at least 24 hours, not during the congestive period. Beta blocker, of course, as I mentioned before, not during the congestive periods after the patient have a stable BP, as well as patient is not showing any signs of congestions, we can start the patients of beta blocker. Beta blocker actually aims for the rate control of the heart, because it is shown that in the long term, rate control of the heart, reducing the heart rates of the heart in itself, will prevent the will antagonize the effects of the cardiac remodeling. I think we've learned this before in year 2 block 1 during our pharmacological lectures on pharmacologies of heart failures. So beta blockers has shown some benefits in a stable patients in a chronic heart failure. However, there are certain contraindications to start the patients on beta blockers, which includes those with bronchial asthma, those with heart blocks, those with symptomatic bradycardias or hypertensions, and those who requires beta agonist therapy, of course, bronchial asthma patients and so on. And if beta blockers is not tolerated, or if we already up titrated the dose of the beta blockers to the maximum, but still there is no effect, then we can consider another type of medications, ivabradine. Ivabradine, I will talk a bit on these drugs later on. And then we have the mineralocorticoid receptor antagonist, the spironolactone. Of course, spironolactone is known to as a potassium-sparing diuretics. So we need to be a bit cautious for those with renal impairments because they cannot excrete the additional potassium. So must be given with care. So yeah, but this is used as part of the management of the chronic heart failure. The dose of the spironolactone, already I put it up with diuretics in the table taken from CPG. And then the fifth one will be the ARNI, the angiotensin receptor neprilysin inhibitor. So this is actually a drug that is used after we give ACE, ARB, but still not working, then we consider ARNI. So ARNI is not routinely being given, but it have a very good effect because as the name itself mentioned that it has two effects. So in those with heart failure, the RAS will be activated. RAS activations will lead to the cardiac remodeling because of the increase in the sympathetic tone as the effect of the angiotensin 2. So in response towards the RAS activation, our ventricles will release the natriuretic peptides known as the BNP. So this is the markers of heart failures that we mentioned before. It's part of our investigation in a heart failure patient in response towards RAS activations to antagonize the cardiac remodeling effect. Our ventricles will release the natriuretic peptides. These will be the markers of the heart failures. One. Second point is that this fact can be used for us to give medication. So the BNP and also the anti-pro BNP, the markers of HF, will act to antagonize the effect of RAS. And this particular BNP and also the anti-pro BNP will be converted to its inactive form by an enzyme known as the neprilysin. So this drug, at the same time antagonizing the angiotensin receptor, it will also inhibit the neprilysin, which is the enzyme that is present in our body to convert from its active to its inactive form. So in other words, it prolongs the half-life of the BNP as well as the anti-pro BNP. So this will counter the effects of the cardiac remodeling. So these are the summary diagram of the mechanisms of the ARNI drugs. So we can see that the angiotensin activation by the angiotensin 2 act on angiotensin receptors will lead to a vasoconstrictions, leading to a cardiac remodeling state. As a compensatory mechanism, our body will release the natriuretic peptides to counter the effect. So neprilysin break down these natriuretic peptides. So we inhibit neprilysin using the ARNI. Okay, surgical management. We have the device therapy, cardiac pacemaking. These are the list of indications for patients where we want to give the cardiac pacemaker as part of the cardiac resynchronization therapy. And also we can opt for implantable cardioverter defibrillator for those having such indications, history of resuscitated VT or VF, and so on. Because as I mentioned before, that heart failure patients is predisposed to have ectopic foci produced within its myocardium. So such list of indications would be so such patients with the listed indications will be indicated to be put on implantable cardioverter cardioverter defibrillator or the cardiac pacemaker. Surgery in heart failures, of course, this just in summary, because this is not the main point of internal medicine, but yeah, there are roles for surgery in heart failure patient. It includes the vascularizations, valve reconstructions for those having the uh, severe mitral regurgitations. We have the left ventricle reduction surgeries, assisted device, as well as the heart transplantation. I think that's all in summary of my presentation. So the reference would be from Dr. Fahana's lectures, inputs from Dr. Umu Afira, CPG, Harrison, Kuma, and Clark, and so on. So I think that's all for my presentation. So I would like to open the floor for any questions or any clarifications that you would like to seek from this particular presentation. I hope all of us, all of are clear with the details that are being given. So I pass the floor to the MC if there is no questions and so on.
Before that, I would like to again open the floor for any question or clarification that you want to ask. You can ask through the microphone or you can ask through the chat box. All participants.
Just want to add something. Kalau what failures, failure symptoms. Failure symptoms refers to the symptoms of heart failure lah. So we have the especially patients who presents with symptoms of congestions. So these are what will bring the patients to the ward. So symptoms of congestions includes shortness of breath, bipedal edema, the bilateral ankle swelling, and so on. So these are the failure symptoms, what we're referring to in ward. I just want to add a point on how we want to club and how we want to present a case of heart failure. So a complete diagnosis of heart failures will be, for example, acute decompensated heart failure, secondary to non-compliance to restriction of fluids, complicated with acute pulmonary edema. For example, that is an example of a complete diagnosis of heart failure. So in ward, in patient ward, of course, they will present with acute decompensation. We don't see a stable heart failures in ward. So those with acute decompensation, a point to be taken as part of the HPI. So first, we need to establish the symptomology of the patient. So we must establish the symptoms of heart failure. So this is actually a framework from Dr. Nick Noon shared before. So the first paragraph would be symptom number 1. Second paragraph would be symptoms number 2. Third paragraph would be symptoms number 3. And the fourth paragraph would be the diagnosis. So we must put the points for our provisional and give the points against for our differential diagnosis. At the fifth paragraph will be the paragraph of complications, where we must mention what are the complications present in this patient, what are the complications that are absent in this particular patient. And the sixth paragraph will be the progressions of the disease, which includes the interventions being done by the attending doctor. So that is how we want to present a HOPI as per Dr. Nick Noon's style. I've used this style before and used it since year 3 until year 5. There are apa maksud HOPI dengan HPI? HPI. HOPI is history of presenting illness. For those who are not familiar with it. So that forms the framework of the history of presenting illness that we must include for our presentation. So of course, part of the clinical history of a heart failure, we must identify the symptomology. We must identify what are the causes of acute decompensation. We must identify what are the complications present in these particular patients, and we must also certify the progressions of the disease per se. I think that's what just some additional points. So pass back to the MC. You can refer to, for more details, you can refer to William textbook of radiology. So basically, in our heart failure, when we have a heart congestion, let's say we have a left-sided heart failures. So when we have a left-sided heart failures, so the pulmonary, sorry, the blood coming from the pulmonary vein into the left atrium and then into the left ventricle. So if the left ventricle is failing, there will be congestions on the left ventricle, leading to a congestions of the left ventricle, congestions leading to the left congestion at the left atrium, eventually congested at the pulmonary vasculature. So if you look at the anatomy of the lung, so we have what we call as the alveoli. So in between the alveoli, we have what we call as the interstitium. So interstitium is where we have our lymphatic vessels, is where we have our nerve, is where we have our blood vessels, which includes the artery as well as the vein for the lung. So the interstitium of the lung, initially, at the initial point, there will be a congestion. So if the congestion is not so severe, the congestions will only remain at the interstitium. So imagine if the congestion has become more severe, or in the website Radiopedia mentioned that if it exceed more than 30 millimeters mercury of the venous pressure, so this excessive volume of fluid will be extravasated from the interstitiums into the alveoli space, leading to the alveolar edema. So it's actually just it will give rise to different pattern. Basically, in interstitial edema is a less severe form of pulmonary edema as compared to the alveolar edema. Both are actually subset of alveolar edema, pulmonary edema. Sorry. You can refer further details at the William textbook of radiology, because these two patterns will give rise to different pattern. When we have a bad wing, that reflects the alveoli already have fluid, so that reflects the alveolar edema, more severe form of pulmonary edema per se. I hope this point. I think basically it's not really important per se lah, just a good point to know. How does it cause hepatomegaly? Tenderness per se, to be honest, I'm not sure of the tender hepatomegaly, but the patients can have hepatomegaly because it occurs in the cases of a right-sided heart failure, or in the cases of a biventricular heart failures or a CCF. So in other words, when we have congestions at the right side, so the right ventricle will be congested, so the congestions will transfer to the right atrium. So we know that the right atriums, we have the inferior vena cava as well as the superior vena cava draining into it from the systemic circulation. So when we have a congestion there, the congestion will be retrograde, move to the liver. So the liver will be congestion will occur at the liver, leading to hepatomegaly. As for why it is tender, to be honest, I'm not sure of that. If I found a point, I will share with the MC, and perhaps the MC can share with us. But the patients can have hepatomegaly if the patients have right-sided or a biventricle CCF.
All right, is there any more question from the floor? Okay. All right. If there is no any question from the floor, before we end the session, I would like to seek the cooperation from the participants to turn on your camera for us to take picture with the speaker for memory. I will give you guys around 1 minute for that.